Yeah, good afternoon from India. And I think this is a really welcome move by the Texila American University to bring the experts on the subject, which has taken 210 countries by storm. There are over 2 million cases all over the world. So I think that is the kind of magnitude COVID-19 already has made. And we really do not know how long we will have to keep facing this epidemic. Now, what we have decided between two of us, I will share with you in 5-7 minutes what we have done in India so far, and then the Dr. Sanjeev will say, that the preventive aspect and the science of this epidemic. So this is the way we will be taking our 15 minutes, and of course we will be available for further question answers as and when required. So let me talk about the India. Now India, 1.3 billion population. There are exactly, if we talk about today, there are 12,370 live cases, out of which 1,508 people have already recovered and gone home. That is 12% of these cases have already recovered. 122 people have lost their life. That brings the figure to 3% of the total cases which have died, unfortunately, in this case. The good point is that 50% of our total cases are confined to the 4 states. We have 36 states in the country. So the good point here is that we are focusing on these 4 states plus few other states wherever there are problems. So we are able to contain our efforts on based on the cases where the states rather, where we have more cases like this. Now, I will say that actually, if you see 8th January was the date when China first reported to the world about what happened in Wuhan. India was very quick to act on it, and on 17th January itself, a high-level advisory committee was formed by the government of India. And we got the first case in Kerala, state of Kerala, which was on 30th January. And from there onwards, there have been very, very slow rise. And we did the unprecedented, lockdown, which is very rare in the country of our size. On 22nd March, our Honorable Prime Minister just told the nation to voluntarily shut down. We called it Janata Curfew. Now, that had a huge impact. The whole country remained within the home. But I think this was the trial done by the Prime Minister. And from 24th March, he came out and announced the complete lockdown. Now, this, I will say, as compared to nations like USA, Italy, and Spain, and few others, nobody has done that kind of lockdown, complete lockdown in the complete country. And this still is continuing. It will last till the 3rd May. And one small caveat has been given by the Prime Minister that on 20th April, the government will review the regions and open the lockdown partially with certain conditions, so that the hardship which is being felt by the developing country like India can also be overcome. So I will say the first emphasis of the government here is save the life. We believe that economy will be able to take care later on, but we don't want to get into the trap that because of the economics we try to compromise on the lives of the human. So I think this is one great, I will say, factor which is countries have not done it. Now, coming to, I actually am the convener of the all industry bodies in India, which we form to advise to the government, what shall we do? I was the convener of the task force, which actually decided what kind of COVID hospitals, what kind of COVID centers, what kind of flu clinics should be decided. Because this we went by the reports from Wuhan and from Italy that 80% cases will need only minor, treatment or consultation through the flu clinics. 15% may need some kind of general hospitalization, and 5% will need ICU and maybe ventilator. So we actually advise government to do the mapping in the entire country and to find out that do we have, let us say, 2 ICU beds per 10,000 adult population. With that, the planning has been done now, and we have earmarked the COVID hospital, which are dedicated COVID. We are not mixing up the patient from COVID and non-COVID. So that is one major action we have taken. And similarly, for quarantining, we have done preparation. Actually, many people are asking us that considering the number of cases, which is very few as compared to the population, which I can tell you here, the total number of cases per million, if you see, it is only 9, which is the lowest in the world. Similarly, total number of deaths, if you see, which is 0.3% per million, 0.3 per million, which is again the lowest. But I don't want to highlight on this issue because we are a very big country, and we don't want to be complacent on this very issue. So the preparation has been done now with the flu clinics, COVID centers, and COVID hospitals. And hopefully, I think the way things are going on, we are getting roughly nowadays, with the lockdown already over for 24 days, we are not exactly peaking, but we are getting around 800, 900 cases per day. Around recently, the deaths have been around 30 to 35 per day. So we understand that this is going to happen for next few more days, and we are only hoping that the kind of lockdown which we have done, over and above, we have identified the hot spots, and we have done complete strip sealing, like military sealing, you can call it, so that people from that hot spot can't come out of their houses. So this is a hardship, but I think this is the way we are dealing with it, because we have not gone for mass testing, which we thought is very difficult in a country like India. So we are only doing testing on the cases which are symptomatic, and that's why the lockdown is perhaps the only way, alternative way, maybe a better way. That, of course, other experts will be able to decide. I think so with this little background on what we have done in India, I will hand over to Dr. Sanjeev. As you already read his CV, he is one of our key experts in the country on infection control and the infectious disease. So I think he will be able to take over from here, what we have done, what preventive strategy we are going to follow. Over to Dr. Sanjeev.
Thank you, Dr. Gyani sir, and thank you for the invitation. I think it has been a fantastic movement to collect people and to globally discuss and see whether we can make a huge difference to fight over this COVID. So as rightly mentioned by Dr. Gyani, the infrastructure, though it being a very big country with a huge population, infrastructure had been a big issue. And COVID, we got our first case on 30th of January when we flew in some of the students, medical students from Wuhan. And these group of students landed up in Kerala. And I run a hospital in Kerala, and that's why we were very, very fortunate and to get our alarms triggered at that particular time. And this was the first medical student who got infected, was isolated, and did pretty well within 14 days. And all those from 1st of February onwards, the state had declared as a medical emergency. And that is how it became highly important, and it became a whole statewide movement. With respect to present signs and symptoms, with the cases which are there within the country, most of them, 81.4% of them are presenting with fever and dry cough. And some of them, they are presenting with running nose. But there are also mixed symptoms which are with the patients are coming. So there are symptoms of myalgia, chills, dizziness, headache, sore throat, and nausea and vomiting. But most of them, maximally, they are coming with fever and dry cough. With respect to Dr. Gyani had also mentioned, but it is very, very key to understand that the global mortality, crude mortality rate is 11.4, and for the country it is 0.3. And I think that is where we have done phenomenally well. And because if we say that we country is not testing enough, but deaths is one area which nobody can hide, and our crude mortality rate 0.3 is, I think, a phenomenal gesture. Our case fatality rate also is for patients who are above 60 is 5.9. And I think as compared to China and Italy, that is also a significantly important figure to note. Our infection fatality ratio is 6.3. And I think if we can judge how the infection is spreading, though they have said that R0 would be close to 2 to 3, within the country, the infection fatality ratio is 6.3. So the Indian Society of Critical Care Medicine, in February, they came out with a position paper and said that just in case if there are a surge of cases which are coming in, what do we do? And because the fourth primary symptoms for these COVID cases were breathlessness. So a very a collective, collaborative triad system was formulated, wherein a respiratory rate of more than 30 and an SpO2 of less than 93 with Q-SOFA score of more than 2, they would definitely get triad. So they would get an oxygen therapy. And if PF ratio is earlier, they thought it would be 150, but now it is less than or more than 300. So if PF ratio was more than 300, they got a non-invasive ventilation. And if it was less than 100, then they got an invasive ventilation as along with early prone positioning, low tidal volume strategy. This was also debated thoroughly within the country that non-invasive ventilation is not going to help and it generates more aerosols. So, but then most of the procedures which is being done like extubation, intubation, tracheostomy do generate aerosols. And that is how they all said that yes, non-invasive ventilation also could be a good adaptive therapy. And then there are close to 40% of the cases right now who would be in intensive care, and we are seeing close to 56% of them not surviving. So the death mortality rate in an intensive care patients is definitely high. With respect to infection prevention and PPE, I think because of the lockdown which Dr. Gyani mentioned, we were very, very fortunate to get that period which was available to us to identify hospitals, identify isolation beds, and also get our stocks together. If you know that there would be close to 70,000 public, there is 76,000 beds, sorry, 7,65,000 beds in the public. But if you look at our figure with respect to isolation beds within the country, it is less than 2,000. Just a positive pressure isolation bed. And negative pressure isolation bed was even less than 100. So within that, we knew that our infrastructure is weak, and the 21 days of lockdown period has given us a lot of time to develop, at least now, as Dr. Gyani mentioned, 600 and plus COVID hospitals and many isolation rooms. The isolation, the infection prevention practices would remain the same. We were using hand hygiene, 1% sodium hypochlorite to disinfect the surfaces. PPE was one of our major area of concern. And I think there is where most of the frequently asked questions comes from each hospital. When, what to wear, when to wear, and what not to do. We restricted our PPE. Most of the areas like the double suit arrangement was restricted to fever clinic where the screening was going on, or in isolation rooms or in critical care area. Otherwise, in most of the front desks, security, parking area, most of the OPD clinic just had a surgical layer mask or maintained physical distancing. there was a shortage of N95, and there is where CDC did come to our help, and there is a reuse guideline which is available. So now PPE with respect to N95 is getting reused, and there is also a premier institution within the country have given 6 N95 masks per doctor, and then they use it on one Monday to Saturday and keep it in the brown bag. And if they've used it on day 1, they don't use it till they come to day 7. And that is how they are reusing it. But those who have got a plasma vapor facility or UVC facility available, they are using that to reuse N95 mask. With respect to lab facility, there were only one lab, which was the referral lab within the country, where most of the real-time PCR test was being done, which soon got extended to 16, then 45, then 113, and now there are close to 216 labs. So there is an accreditation body within the country, National Accreditation Board of Laboratories, which Dr. Gyani was heading a couple of years back, and that accreditation body is now certifying labs who can do RT-PCR, HCV, or H1N1. If they have the SOP, if they have the facility, the infrastructure, and if the kit is available, then the RT-PCR testing certification is being given to all these centers. There is also a rapid antibody testing which has been permitted now. So there are 13 premier medical colleges which have been identified within the country, who in turn are going to teach and train 600 plus medical colleges where rapid testing could be done. So I think the intent is that can we identify if there are community transmission, test, as WHO Director General has said, and identify if there are any hotspots with respect to that, and isolate or quarantine these facilities. With respect to pharmacological treatment, there is an antiviral. There are dual antiviral which have been used. There is a lopinavir and ritonavir which is being used in these patients. And if the H1N1 is coming as positive within this RT-PCR, then oseltamivir is also added. Recently, last week, ICMR has also, they have called for action. They have called for all those institutions who would like to adhere to plasma therapy, and this permission has now been given. So that would be an additional treatment facility which would be started within the country. Up till now, no hospital has initiated it. Up till now, no hospital has also, because of hypoxemia, taken any patients on ECMO. And so that is the position as of now. And the lockdown period, as Dr. Gyani has said, has increased for another 3 weeks. And we would possibly see that it is contained and coordinated well within the country. There is huge participation from the private sector as well. One good point was that all these patients are treated in COVID hospital, which would be public hospital. But when the surge comes in, the private setups have been asked to identify quarantine bed, isolation bed, and critical care beds to jump in whenever the resource would be required. So that is it from our side, and I will ask Dr. Gyani to sum up if there are any missing points within this session.
I think this has been wonderfully very well placed, both the side, administrative side, preparation side, and the clinical side, what Dr. Sanjeev has presented to all of you. I think we will look forward if you have any questions, or otherwise you can proceed with your normal agenda. Thank you so much.
Thank you, Dr. Sanjeev, and thank you, Dr. Giridhar. So we have few questions. I think Mr. Rajesh Kannur had suggested plasma therapy is a very good choice. And we have a member, Mercy. The question is, during this lockdown, how did you manage movement of essential workers, doctors and nurses working in COVID-19 hospitals and clinics?
Okay, let me answer partly. We have issued the what we call curfew passes during this period, number one, for all the workers which are associated with the healthcare functions. And there has been separate order that anybody having the hospital pass, identity card, he also is allowed to move around in the entire country. So I think this is the way police will allow them to move around.
Fantastic, Doctor. Thank you. Hope Ms. Mercy Mimbiwe, hope your question is answered. The second question from the participant, Mr. Erastus Mianda, how sensitive and specific is your rapid test?
Dr. Sanjeev?
Yeah, so that is that's a difficult question. I do understand that RT-PCR, and that is what ICMR has also maintained, that is the gold standard. Now, within this, there is also addition of, because that was so limited because of the infrastructural requirement, the rapid testing, the rapid antibody testing has also been introduced. I do agree the sensitivity would be definitely lesser, and it is close to 53% with specificity of close to 45%. And also it is important to understand that the antibody test would be available. If it is IgM, it would be available from 8th day, and most of the infections would be seen on the first, second, or third day. But then that is a good point of care test which is available, rapid, and would possibly help us in identify that community spread.
Okay, thank you, Doctor. Thank you, Dr. Sanjeev. The next question from the participant Chiluba. How are the disinfecting PEP that's being reused? What drugs are you using for the treatment of symptoms of COVID-19?
So as I mentioned, N95 is the only thing which is being disinfected, because it's costly. Second, not everybody needs to wear it. So N95 disinfection right now, there are two things which are going on within the country. One is that in one premier hospital where resource crunch is not there, they have given per healthcare worker 6 N95 masks, and they use it on day 1 and day 7. And that is how they keep rotating, and they have been asked to keep it in a brown bag, with an assumption that the mask, if the virus is still there, it would not be there more than 3 days. That is one. Second is that there are two sterilization technique. One is UVC ray, and there is plasma wafer, which is being used, and the institution is being using. Third is that ETO is a complete no-no. Alcohol wash or soap wash of N95, the integrity is not maintained, so it is completely no-no. Now to the second question, what drug is being used? I think it is a dual antiviral, lopinavir and ritonavir, which is being used. And if H1N1 also is positive, then oseltamivir is also added.
Fantastic, Dr. Sanjeev. The next question from the participant Mubzi. For health workers working in the ICU, would it be advisable for CPR to be performed given its aerosolation?
Yeah, absolutely. Because whatever deaths you can, you may be able to withhold, or you may be able to take care, should be taken care of. If you are following universal standard precaution, and if you are following your PPE kit, the aerosol generating PPE kit within the critical care unit, CPR also needs to be done, because there is absolutely, because they are doing much harder processes like intubation, extubation, tracheostomies. Though the technique right now would be rapid, but it is all been done. Those are more harder aerosol generating procedures. So CPR definitely is not. So if it is required, it needs to be done, because we need to save lives.
Fantastic, Doctor. Thank you. The next question is, I think we have two compliments from the participants. Thank you for the presentations. You were on track, and how do you arrange knowledge updates of, okay. So you were on track, but how did you arrange knowledge updates for all these frontline workers? It's a compliment from a participant. And the next question from a participant, Mr. Prabhu, is COVID-19 the same as SARS? And what is the cause for it?
No, that COVID-19 is not same as SARS. That is why it is called as novel, because it comes from the same family as SARS and MERS, Middle East respiratory syndrome, but it is different, and it is different genotypically, and it is a double S RNA, and that is why this is called as novel. So the short answer is that it is SARS and COVID is not similar. And there are various varieties, alpha, beta, gamma variety of COVID present right now.
Thank you. Thank you so much, Dr. Sanjeev. I think for now, I think that's the questions from the participants. So thank you so much, Dr. Giri, once again, as well as Dr. Sanjeev, for your valuable information to the participants from Zambia and across Africa about this COVID-19, the first session.